So dysrhythmias are broken into two categories. Problems with the atria and problems with the ventricles. And so when we're talking atrial dysrhythmias, if you look on page 69 of your book, what's the rate on that rhythm? It's going so fast though. Where the heck is the P wave? What's actually happening, because the rate is 170, that P wave is buried in the T wave from before. It's very difficult to differentiate what rhythm that actually is. But a lot of times we'll call a rhythm that's getting up in the 170s, 180s, 200, 220, supraventricular tachycardia, SVT. And what that really means, we got our atria here. Supra means above the ventricles, supraventricular tachycardia. And so what that really means is we don't know what's causing it or where it's coming from, but it's coming from above the ventricles. How do I know that? Somewhere up in here there's a crazy pacemaker cell that has taken over. It's firing like crazy. And it's above the ventricle. The way that I know that is by measuring the QRS. The QRS in that is still nice and narrow. It's less than 0.12. To tell you what the alternate would be, I'm going to flip a few pages. On page 30, do you see the difference there? If we were to measure that QRS, is it greater than 0.12? How many little tiny boxes under any one of those? There's a lot. Definitely more than 3 little tiny boxes. The reason this is important to know is VTach may or may not have a pulse. This rhythm on page 30, if you go in and check this patient, is he alive or is he dead? It's a crapshoot. Don't know until you go in there. Just looking at this on the monitor, you don't know. This is called VTach, and it's going to turn into VFib very soon. The way that goes down is you've got a patient in VTach, you don't treat it, a few minutes later it starts getting smaller and smaller, and now he's officially fibrillating. And then what comes after fibrillation? Asystole. And so VTach is just a continuum of sudden cardiac death. Sudden cardiac death continuum. And at this point, it's no longer sudden cardiac death, it's just death. We want to shock this person before they reach this point, because they're still not completely dead. They're just mostly dead. If we shock them, we can potentially get that sinus rhythm back. I don't think you'll have this on a test question, but you might. If you're testing really high on the NCLEX, you remember how I explained how the super hard questions mean you're doing really well? If this guy has a pulse, when you go in the room, I had a guy come in and I said, what's the emergency? I said somewhat facetiously because it was 2 in the morning and it was an ice storm. And I'm like, why are you out of the house in your SpongeBob pajama? And he said, my big toe, I think it's infected. I thought, okay. And I took his vitals, and his heart rate was 180. And I thought, well, that's peculiar. And I told him, I'm going to hook you up to the heart monitor. Your heart's really racing. And I hooked him up. He had just walked in and still talking to me. This is what I see. So sometimes these guys are completely dead, and sometimes they're walking and talking. So then the next question is, should we shock this guy? Should we defibrillate him? Should I hook up the AED and get him back into normal sinus rhythm? The correct answer is, if he has a pulse, we do what's called a synchronized cardioversion. Synchronized cardioversion. And that sounds really like super scary, and gosh, because that's a nursing function. Nurses do it all the time if you're ACLS trained. The synchronized cardioversion just lines the shock up to that QRS, and all this really means is you see this little button on the defibrillator, and it says sync. S-Y-N-K. That's the only difference between defibrillation and synchronized cardioversion. We defibrillate if they're dead. That's how I remember it. We defib if they're dead. If they're still alive, we push the sync button and do what's called a synchronized cardioversion. And for this guy who was walking and talking and perfectly fine, we had time to start an IV, load him up with a ton of Versed and morphine, make him happy, and then shocked him. But for most of those patients who are truly dead, you don't have time to mess around. You're just going to go straight for the AED. I got this phone call in the middle of the night from a volunteer ambulance. Josh, we're bringing you a patient, but not sure what to do. The AED says to shock now. What should I do? I'm like, well, I don't know. I didn't really trust my AEDs. And then I thought to ask, what's the patient look like? I mean, how dead are they? They really dead? He goes, oh, she says she's fine. Oh, where are you calling me from? Back of the ambulance, heading down a dirt road at 50 miles an hour. The AED was just picking up, the back of the ambulance is there. So the AED was seeing this. So,
thank God they called.
yeah.
Just push the button.
Don't push the button, I said. Don't push the button. So I skipped clear up to ventricular dysrhythmias. If you see that next one on page 31, anybody have any ideas as to what to call this rhythm? It's kind of looks a lot like our VTAC, doesn't it? But it's changing. And so some people will call this like torsade de pointe, but the technical term is polymorphic VTAC. What that big fancy word polymorphic means is it's coming from different pacemaker cells in the ventricle. And so you can literally see the difference. This VTAC over here, it's one crazy pacemaker cell that went nuts in the ventricle. In this rhythm, it's a bunch of pacemaker cells have gone crazy. And it looks a lot like fibrillation. So we would just treat this like ventricular fibrillation, this here. Because I guarantee this guy doesn't have a pulse. So we know what to do for AFib. We know what to do for VFib. On page 19 is what we would call a first degree heart block. And that's just a normal sinus rhythm. On page 19, normal sinus rhythm, but our PR interval is a bit too long. The PR interval is greater than 0.20. First degree AV block. What do we do about that? Nothing, we don't care. It's most likely caused by the patient's heart meds that he's on. He's on some cardizem and some DIG and some beta blockers. We don't care. There are 2 second degree AV blocks. One of them is called the Winky block. And that's on the next page, page 20. And what is happening there is the PR interval is getting slightly longer, and then they drop a beat. On the PowerPoint, there's this slide that explains the different AV blocks. First degree AV block, we don't care about. Second degree AV block, type 1, don't really care about. That's called a Winken block. Why don't we care about it? Because it goes away and it's transitory. And so the most common patient that has a Winky block type 1, what a Winky block looks like is the P, QRS, T, and then the next time the P is quite a bit farther away, QRS, T. The next time it's even farther away to the point where maybe there is no QRS, and then it all starts over again. This PR is walking away. The PR is walking away, the P wave is walking away from the QRS. That's called a first degree type, or second degree type 1 Winky block. The most common patient doing that is a little old lady who refused her Miralax the night before. And she's constipated. And I've ran out of the ICU many a time because we used to monitor the rhythms and we'd have to respond to any new blocks, run out, go check on her. And she says, leave me alone, I'm in it. Slams the bathroom door. She's bearing down. Bearing down. That's called the Valsalva maneuver. And it causes a Winky block. And then as soon as she's done in the bathroom, it goes away. We don't worry about that too much. The 2 AV blocks we worry about are these 2 right here. The type 2 and the third degree. Both of those patients are going to get a pacemaker. The key difference on page 22, the big thing you're looking for a third degree AV block, complete dissociation from the atria to the ventricles. There is no communication whatsoever between your sinus node and the lower half of your heart. Some cardiologists call this decapitation. You know, if you chop your head off, there's no communication. And so in that rhythm, you have a sinus node firing at its normal rate, 60 to 100, but that is not coming down into the ventricle. And so that third degree AV block looks like a ventricular escape rhythm, the QRS part. Because what's the rate of this, if you count your QRSs across here? And if you feel this patient's pulse, that's exactly what it would be. A pulse of 30. But if you count the sinus node rate, do you see all those P waves in there? 1, 2, 3, 4, 5, 6. There's one buried in that last QRS. That sinus node rate is 60. The 2 halves of the heart just aren't communicating at all. So we could have the ventricle rate of 30. That's a third degree AV block. It's like decapitation. The atria and the ventricles aren't communicating. And we can give all the atropine in the world, not gonna help. We have to just put a pacemaker in. Third degree AV block. If you were to use your calipers, those QRSs are perfectly regular, and those P waves are perfectly regular. How do we treat a third degree AV block?
Pacemaker.
Pacemaker. How do we treat AFib? There's really two things we worry about. The blood clots, so we're gonna put them on blood thinners, and make sure their rate doesn't get too crazy. Always assess before you intervene, what's the treatment for asystole?
Make sure that they actually do.
Make sure their monitor's actually attached. Their lead didn't come off. Look at your patient. Always treat your patient, not the monitor. You guys remember milrinone? I talked about milrinone.
Except on the test.
Except for on tests, we give it. We don't give it in real life because it just tends to kill people. One other thing, central venous pressure, what's normal? 0 to 8. And so what does it mean if it's really elevated?
Heart's not beating right.
Yeah, you got fluid backing up. Fluid backing up, and so that's a symptom of heart failure. What's it mean if it's really low? Dehydration, yes. Vasodilators, like nitro, are a great way to treat a super elevated CVP. Fluid backing up, we're gonna give nitro, we're gonna give morphine, we're gonna give Lasix, dilate everything out, and get them an EM.